This MediSync ECG review will focus on case number 335 from ECG Wave-Maven. Copyright information is provided here. A 47-year-old woman with a history of breast cancer and a life-threatening problem. Echocardiogram showed normal ventricular function and no pericardial effusion. This ECG is most consistent with which one of the following diagnoses? The answer, acute pancreatitis. The ECG shows a number of salient findings, including sinus tachycardia, long QT, QTC, low limb, lead, and lateral QRS voltages, along with non-diagnostic slow R-wave progression in leads V1 to V3, and non-specific STT changes. The only diagnosis listed that accounts for the major findings is acute pancreatitis. The long QT is due to hypocalcemia. Sinus tachycardia is due to neuroautonomic activation in this context, and the low voltage is consistent with ascites and a sarca. There is no evidence of acute MI by ECG, and the echocardiogram was unremarkable. The literature and clinical lore suggest that both acute pancreatitis and acute cholecystitis can directly produce ECG changes exactly simulating acute MI. However, it's probably best to remain skeptical of this association with these two very common conditions. Findings of ST elevation in pancreatitis or cholecystitis should not be routinely attributed to the underlying abdominal pathologies, and acute ischemia and related syndromes should be carefully excluded. At the same time, systemic anticoagulation of patients with acute abdominal emergencies that occasionally are associated with ECG changes mistaken for acute STEMI can be catastrophic.